Hey everybody, this is me again. Let's talk about neonatal resuscitation. Here I have a little preemie infant. It's kind of realistic looking. Let's go through some scenarios, some basics that can be very, very helpful. Let's go with assessment. So what are one of your primary indicators? Let's talk about some clinical signs right here. Here we're dealing with prematurity. And a lot of times we're dealing with hypoperfusion because in utero these infants can stress, and based on the mother's physical condition and whatever stress that the infant is going through in utero prior to delivery can definitely affect outcome. So when these infants come out, you don't want to waste too much time. If they're really small, you can dry them a little bit, but get your leads on there as soon as possible. It's a good idea to get your pulse oximeters also, but keep in mind that a lot of times these infants are very hypoperfused, and pulse oximeters don't pick up too well. So sometimes if I have time, I'll do a pre and a post-ductal also. To rule out PDA or issues like that. But let's just say this infant comes out. What is the first thing I'm going to do? I'm going to position, dry. You don't take much time. Suction the airway very quickly. Let's just say at this point that this infant is flaring and grunting. A good idea is to get your T-piece. And remember, you always want to have your TP set at about 25 over 5, 25 being the top number, and then 5 being the CPAP. And I would not go over 5 centimeters of water pressure to CPAP in an infant, for that matter, in a situation like this. These T-pieces are great because they can do a lot more things that your conventional self-inflating ambu bags cannot. Okay, so for example, if this baby here is flaring, I already have him dried and positioned. If you have any flaring and grunting, go ahead and do a little CPAP. All right? You don't want to take too much time doing CPAP. Again, what is our best indicator or your best clinical sign that the infant is responding well? That's going to be increased heart rate. Of course, the saturations. So remember, we're not in too much of a hurry to get these saturations above, 80, 85%. We're not looking for that because of the vasoconstrictive effects, and when they're premature, that can be detrimental to the baby too. So at this point, I'm doing CPAP, maybe 30, 40, 45 seconds. I'm watching the retractions. I'm checking capillary refills. I also like to get sugars as soon as possible too, because that can definitely play a huge role in the outcome of these little ones. So I'm doing a little CPAP for this kid here, and then I kind of keep the blow-by nearby, so I'm either CPAPing or doing blow-by, or I end up doing positive pressure ventilation. You can do all three with these. Very effective little mask right here. So let's say that this infant now, is still grunting after CPAP, and when you have prematurity like a premature infant like this, you're going to have to end up establishing an airway. Let's say I'm not getting good chest rise, but let's just say that my heart rates and let's say that my saturations are still going up, right? Well, at this point, if they're gasping, of course, if they're apneic, I'm going to go ahead and start positive pressure ventilation. So remember, if you have any kind of heart rate to work with, remember, positive pressure ventilation is the appropriate thing to do. You want to look for chest rise. Be careful, because you're manually doing this. I'm covering this here hole right here, see, to get my inspiratory pressure. You don't want to leave your finger on there all day long. Anywhere between a 0.35 to 4 second eye time is good. And you kind of get used to it. So right here, I don't know if you can see that I'm getting a chest rise right here. Just do that away right here. See that chest rise? Again, flaring, grunting, retractions, go ahead and do a little CPAP. Get a good seal. Get your little C-clamp going. I'm going to regulate my CPAP right here. Remember, I don't want to go over 4 to 5 centimeters water pressure right there. So, if you're not getting good results with oxygenation and chest rise while you're doing your positive pressure ventilation, it's time to go ahead and get an airway, because you're going to have to give surfactant anyway with these premature infants, all right? So, but I'm going to continue my positive pressure ventilation until my saturation stopped going up and my heart rate stopped going up. Let's say my heart rate went from 10 to a heart rate of 60 or 65. At that point, I'm not going to get my heart rates any better. I'm not going to get my saturations any better than 40 or 50%. So at that time, I'm going to definitely be prepared to intubate. Now, everybody has your choices. I've got little small blades here. You have the double O, and then you have the O blade. And so I just use a 0 for all the kids. And there's nothing wrong with using a double O for super small ones, maybe 23, 24 weekers. That is fine. Again, my intubation technique is simple. Everybody has their way of doing it. This again is a fiber optic laryngoscope here, which I like a lot. Remember, I'm going to choke down on that tube. I'm sorry, I'm going to choke down on the handle. What I'm going to do is use my middle finger initially as a fulcrum for the back of the neck. I'm going to have full control of the head with my index finger underneath the chin. When I insert, I'm aiming that laryngoscope blade straight down. I don't want to go in like this because you're going to cause some damage. Keep the head steady. As you're going in, you see my hands? Right now, my pinky is on the back of that baby's, right on top of the neck right there. So as I go in, my hand comes toward the baby's head. Now, I have full control of the infant right here. I'm off the upper palate. I'm not doing any damage. I don't use stylettes. Remember, you're going from the side to not obstruct your view. All right? Be careful with your depth. All right? And once you get that tube in there, I want to stick my finger in that baby's mouth immediately to keep the tube in place. And we're going to hook up, and see, we got chest rise. All right. So right now I'm ventilating the baby at about 25/5, getting good chest rise. I'm going to go ahead and secure my tube and get ready to give the surfactant. Very good. All right. Hope everybody enjoyed that little lesson right there. And stay tuned for the next one. We'll be talking about securing the endotracheal tube and some techniques with tape, and also administering surfactant, how to dose, and how to use the MAC adapter. Y'all take care. Bye.